I really appreciate everyone taking the time to attend the presentation, and I hope everyone is staying safe and healthy during these very trying and very strange times. I have to say that I feel it's been a major adjustment at many levels for myself. So I can only imagine how it might be for others, kind of adjusting to this situation. Um, so yeah, this morning I would like to engage in a dialogue with everyone on the webinar about an aspect in Parkinson's disease, which is the presentation of depression. This is a fairly common situation, and my understanding is that only recently it's become a bit more of the focus of attention. So we'll talk more about this in detail, but I really appreciate actually the opportunity to start talking about this and kind of creating more of a culture of talking about these other non-motor symptoms in the context of Parkinson's. And just as a way of a brief, really brief 1 minute background, the way I got to this was I'm a psychiatrist and faculty in the Department of Psychiatry, and my main area of work is both clinical and in research is treating treatment resistant depression. And we use in research we use a set of tools called non-invasive neurostimulation treatment, and in discussions with colleagues in neurology, the idea of using some of these tools to treat Parkinson's disease kind of was emerging, and eventually it led to my working at the Pacific Parkinson's Research Center as a consulting psychiatrist, because my colleagues in neurology would tell me, oh, well, this is an area of need. We need that additional help to address this area. So that was, I believe, 3 or 4 years ago, and it's been a very rewarding experience, both personally and professionally, because it's given me yet another vantage point about depression in the context of a different medical condition, Parkinson's. So I have to say that today I'm trying to give back a little bit of what I have learned from the people that I've looked after over this year. So hopefully that will be a little bit of giving back, and I'm certain that I'll be learning a lot from all of you as well, from your questions. I was telling Amy before starting that I might have erred on the side of caution in terms of the number of slides, but there's not too many. But what I would like with the slides is to prime discussion. So I'm hoping to get through the slides in 30 to 35 minutes tops, and then have an opportunity to engage more in dialogue and addressing questions and learning from you, from your questions and from your experience. So I believe Amy will share the slides, so everyone will have the slides. I'm not going to spend a lot of time on my disclosures, but I think it's important for everyone to know what those potential sources of conflict of interest are in my work. I have no shares or explicit conflicts of interest with any pharmaceutical or device manufacturing company. The lab, as a researcher, has received in-kind equipment for research that we have initiated, and I have to disclose that I will be discussing off-label applications of neurostimulation. That's a very important aspect. In the latter part of the talk, when I'm discussing neurostimulation, it's very important that I make it very clear right from the outset that one part of that will be discussing an off-label. What does off-label mean? Devices, medications, they go through a very thorough and detailed process to be approved for a given condition. And that's what it's called when you prescribe a medication for that condition that's been approved. We call that on label. If we're using it in a different context, in a different condition, we call that off label. And it's important for people to know that and to have a discussion before doing that, so that that context is made explicit. So I thought it was important to spend a little bit more time on that aspect right from the get-go. I'm gonna guess that no one has seen a slide like this before in this group. I'm just kidding. But this slide it's a very condensed summary to say that we know that Parkinson's disease is a very common neurodegenerative disorder. It's the second most common after Alzheimer's. That the age of onset usually for non-familial Parkinson's disease is around 60 years old. And right from the description, the early descriptions of Parkinson's, the emphasis, rightly so, because that's how it presents and that's the main kind of group of symptoms, was describing a set of motor symptoms. And neurologists call this the motor syndrome. And we've learned over time that within what we call Parkinson's disease, there are also kind of subgroups where the symptoms can present together, and so that not everybody has all the symptoms all the time, like the tremor, the rigidity, the decrease in speed of movement, or the instability. There are people who present with one or two of these symptoms as the main presentation, as the main symptom that they struggle. So it seems that there might be within this umbrella of Parkinson's disease subgroups. So traditionally and for decades, the emphasis has been to address these motor symptoms. And again, my understanding is that only over the last maybe 20 years or so, there's been a bit of a shift to discussing more the non-motor symptoms. And the main reason why the emphasis has been a lot on motor symptoms is because that's, number one, it's the main symptom that presents, but it's also because the pathophysiology, so why the illness presents, is tightly related to how motor areas are involved. And again, you've probably seen a slide like this or similar, where you can see an image of the substantia nigra, which is that part of the brain where there is a very dense concentration of neurons, brain cells that produce dopamine, and those brain cells project kind of axons, wires to the rest of the brain, to different areas. And one of those areas where those projections project to is motor areas, areas that help us coordinate and kind of enable us to move. So that's why motor symptoms are prominent. It's the main manifestation. But over time, we've learned that these dopamine cells, their projections also go to areas of the brain that regulate other aspects. And that's become to be known as the non-motor syndrome in Parkinson's disease. I've listed here a non-comprehensive list of those non-motor symptoms, but this is to illustrate that in addition to that motor syndrome, there's an array of other symptoms that interfere with quality of life a great deal. And sometimes some of these symptoms that you see listed here do not respond. The medications that we use to treat the motor symptoms might not work that well to treat some of these symptoms. So I think the field has realized this for quite some time now, and there's been an increasing interest to help and to find treatments for these non-motor symptoms that get in the way in life. Just to go over them a little bit and classify them, and I'll speak more specifically about depression today, so I won't be able to cover all the list, but we have more psychiatric mental health symptoms. Depression is one of the most common. Anxiety is also very common, and sometimes they present together, and even sometimes the presence of psychosis or hallucinations or delusions can emerge in the context of Parkinson's. Then there is a group of symptoms like sweating, the constipation, hypertension, or sexual dysfunction that seem to be tightly related to a part of our nervous system that it's called the autonomic nervous system. The autonomic nervous system is a group of neurons, a group of nuclei in our nervous system that help us regulate a lot of functions that we are not aware of. Bowel movements, temperature, the rhythm of sleep, there's blood pressure, heart rate. We're not aware of that, but our brains or nervous system regulates all that tightly. So it seems that when those dopaminergic neurons are affected, not only we get motor symptoms, but other areas of the nervous system are impacted, and then other symptoms that are not directly related to the dopamine dysfunction per se emerge. And those would be a good example. So I'm going to focus now on depression. And depression in the context of Parkinson's disease, the first key idea is that it is very frequent. Some estimates, and there's a reference here, estimated is around 40% of people with Parkinson's disease develop depression during the course of their condition. We'll talk more about this, and I suspect there might be questions about this, but sometimes the depressive symptoms appear before even the motor symptoms, and it's only later when the diagnosis of Parkinson's is being made and we just look retrospectively, we realize, oh, depression kind of happened a few years before the motor symptoms were obvious. So there are other types of subtle signs that can emerge before the full motor syndrome appears that are hints that maybe something is happening, and depression can be one of those. There's a bit of an area of uncertainty, and we don't know yet enough to distinguish and tease out people who might have depression as a first and primary mental health diagnosis disorder, and then develop Parkinson's, and so they have two separate conditions, versus depression that is tightly related to the Parkinson's. In my experience in the clinic, My impression is that both situations can happen, so that someone has condition number one, depression. It might start in their 20s, in their 30s. Then they develop a second illness, Parkinson's. And what happens in that situation is that Parkinson's makes that first problem even worse. A different situation that I've also observed is only when Parkinson's or the process underlying the Parkinson's disease starts to impact brain function, only then depression emerges. The reason why I'm spending some time on this is because it might, the implication of these two different trajectories for depression might have a lot of implications in terms of how we treat depression and how people respond to different treatments. It's an area of active research. I think we don't have yet the tools or enough knowledge to be able to clearly distinguish those two situations. In any case, and no matter which one of those two situations the person is presenting with, it is very clear, and there's research documenting this, showing that depression has a significant impact on quality of life. And it's a condition, a situation that needs to be addressed and treated to improve quality of life. So I'm going to preview the content of this slide by acknowledging an intrinsic challenge that psychiatry as a medical specialty struggles with, which is the fact that still now we do not have any tests, any diagnostic tests that help us psychiatrists to diagnose any mental health disorder. Depression, anxiety, doesn't matter. We don't have those tests. And so we are still wrestling with that aspect of how we go about making diagnosis and how we are able to distinguish different mental health disorders and what is a mental health disorder from neurological presentation. So that's a limitation that we have yet. And I was reflecting about this morning, and I was thinking, well, wait a second. People don't get tests in neurology when there's a suspicion of Alzheimer's or Parkinson's. There's no such a thing either. That's true, but the reality is that we do have tests after the fact. And so in both situations, both Alzheimer's and Parkinson's, we know for fact we have those studies looking at the brain post-mortem showing, so there's the evidence there that, oh, this is what was happening. So I think that makes a major difference. And this aspect of not having diagnostic tests and not knowing what is the underlying biology of depression or anxiety comes up a lot, and it brings a level of uncertainty that as a professional I have had to learn to deal with and convey what we know and what we don't know. So all this was to preview that to make a diagnosis of depression in the context of Parkinson's does present some challenges, because some of the symptoms that as a psychiatrist I look for to help me making that diagnosis of depression just happen to have overlap with the symptoms that Parkinson's as a neurological condition presents with. And very good examples of that is the decrease in facial expression, the modulation of voice, or the speed of movement. Any of those areas in isolation are also aspects that I try to observe when I'm making an assessment and I'm trying to make a diagnosis of depression. And here we have the situation that those symptoms can present as part of the Parkinson's disease. So how do I go about, how do psychiatrists go about teasing out, is this Parkinson's or is depression? Uh, I will say that it is an area of research, and that over time in clinic, I I do believe that there are subtle differences in these symptoms when they are part of the Parkinson's and when they are depression. And hopefully we are planning to engage in research to tease that out and to show that there can be ways of distinguishing them. The other aspect that helps with a diagnosis and trying to distinguish is whether the symptoms present together in a constellation that is suggestive of depression or Parkinson's. So I guess the concept here is each of these uh, symptoms that are listed here in isolation, if we look only at this, could be part of either Parkinson's or depression. But it's when they present together in a certain way in a timeline that are more suggestive, or that hint more, no, this is the Parkinson's disease, this is the dopaminergic dysfunction that is causing these symptoms, or no, there's something in addition to the Parkinson's, there's depression. And I think that ties in with another challenge, which is the aspect of, and in psychiatry, when we try to make a diagnosis of depression disorder, we struggle with this as well, which is the depression a disorder, is a condition, or is this an adjustment? Is this a reaction to a very transcendental life event, which in this case is the diagnosis of Parkinson's? And here is a very another good example of things that I have learned at the clinic and learning from patients that I looked after. There's no question that, and it's very interesting to see the differences. Parkinson's is a condition that presents late in life, in 60s, in your 70s, as opposed to primary depression, which tends to present in your 20s, in your 30s. And Parkinson's, in that context, most of the time, many people, they get to that time point in their life having developed their full potential. They've lived lives, family. They were kind of free of Parkinson's up to that point, right? And so the presentation of Parkinson's is a major event and a major adjustment. And a line that I've heard from many people that I've seen at the clinic is, I didn't imagine my retirement would be like this. I didn't envision that this and this condition changes all. It changes it all. So that is connected to that aspect of loss. And whenever we experience loss, we go through a process of grieving. And the diagnosis of Parkinson's by itself can represent and represents to everyone a loss. The loss of something that was a potential and now has changed. And it's transcendental. So adjusting to that can be associated with feelings, with emotions. And feelings and emotions per se are not a disease. Feeling sadness, feeling grief, that's not an illness. We feel, it's part of life. And then So all this to say that sometimes where is that that distinction between there's a reaction that I would expect most people that go through a significant life stressor or event like a diagnosis of Parkinson's would go through, and when it becomes a disorder, a mood disorder, that distinction sometimes is challenging, but that's one of the things that I have learned. I have heard many of you sharing your experiences of loss and grief, and some people that do not struggle with depression. Kind of, I can see how that was a loss where how people went through grief and how they adjusted, and they might struggle with anxiety, but not with depression. And when depression is in the picture, then it starts to look different. And one of those differences, and I apologize if it sounds very vague, but when it's depression, when it's the mental health disorder that emerges, it starts to get detached from that process of grief, from that process of loss. It starts to be more pervasive, not connected specifically to that theme. So that's a hint that helps making that distinction. The last challenge that I want to share with you is that aspect of, and we've talked about this a little bit already, but is that aspect of whether the mood disorder, the depression, is a primary, so it's more like a depression disorder that started in the in 20s, 30s, and then the Parkinson's is a second illness, or whether the depression is a result of the Parkinson's disease. And I already mentioned this. Something that helps a great deal is that the timeline of when symptoms and the conditions emerge. That helps a great deal to tease out this one a little bit. And of course, the implication, and I hinted at this earlier in the presentation, primary depression, mood disorder, has a number of treatments, and we know their efficacy, whether they work and how often they work. We don't have the same amount of knowledge about the efficacy or how well these treatments that we use for major depressive disorder versus depression in the context of Parkinson's. And that leads me to this slide, where studies that have looked at whether these antidepressant medications that we use for major depressive disorder help for depression in the context of Parkinson's. And they do, but that effect seems to be modest. The overall impression, and there's not been a direct comparison, meaning comparing how well they work in depression in Parkinson's and how well they work in depression in primary depression. That study, I'm not aware of it. It might exist, but I'm not aware of it. But it would appear that they work less well, the antidepressants for depression in the context of Parkinson's. And the second point of the slide, I think I've been talking about this for quite a bit, and if there are things that or additional questions, I'm happy to address them later on. So in the context of not knowing for certain whether antidepressant medications help as well, or having some data that they have a moderate effect, the looking for additional treatment options is a necessity. And here's where it comes, and the talk now is going to shift to talking about non-invasive neurostimulation treatments. And non-invasive neurostimulation treatments are a group of treatments that fundamentally rely on the use of a physical means to elicit to the treatment effect. I realize kind of listening to myself, that was a very complicated way of saying that we use electricity, we use current to stimulate the brain as a way of the treatment of these modalities to help. And there's a group of treatments that have been used a lot for depression, and there are data showing that they can help for depression in Parkinson's, which are the convulsive treatments. And on this slide, as you look at the slide, on the left-hand side, you have electroconvulsive therapy or electroshock, and on the right-hand side, magnetic seizure therapy. Whereas ECT has been used and we know has a role in the treatment of depression in Parkinson's, magnetic seizure therapy is that treatment that I mentioned at the onset of the talk, that it's in the research realm. We still don't know, those clinical trials have not been finished. So MST is the research, ECT is what we know about. These two treatments work in a similar way in that they trigger a seizure, a controlled seizure, as a way to trigger in the brain a lot of events that can help treating psychiatric symptoms. ECT is the most effective treatment that we have for severe depression. It works in 80% of people that receive the treatment, and in 60% of people, it leads them to what we call remission, so barely no symptoms left. The main problem with ECT is that the side effects that is associated with can be very problematic, and one of the most troublesome of all is that ECT can be associated with difficulties with memory, with amnesia. And so that is a side effect that is problematic, and that's why we tend to use it in situations where depression is severe. Magnetic seizure therapy triggers a seizure as well, but uses a different physics mechanism. And that's why the icons here are different. For ECT, you see a light bulb because the mechanism is delivering current directly, so the current flows in the brain to trigger the seizure, whereas the magnetic seizure therapy uses strong magnets to stimulate only the outer part of the brain, the cortex, to trigger the seizure there, and that spreads to the rest of the brain. All the data that we have so far in the primary depression, so in major depressive disorder, not in Parkinson's and depression, in major depressive disorder, shows that MST has significantly less memory side effects than ECT. So there are ongoing trials in major depressive disorder looking at whether MST works as well as ECT, but with fewer side effects. So I started to talk about this, about what ECT is. And again, I don't want to beg the question or the aspect that ECT is one of the most controversial treatments that there are in medicine. It has a lot of stigma associated with it. The portrayal of ECT in many movies is not accurate with how we practice ECT these days, but it portrays it in a very negative way. And over the years, I've become to appreciate where part of that stigma might come from. And one part is the aspect that we fear electricity. We just it's ingrained in us. Lightning is scary. When we get static current, it's an unpleasant sensation. And so the idea of using current to the brain is very counterintuitive. It's like, oh, I'm not sure about that. On top of that, the idea of passing current to trigger a seizure, which is outside of ECT, a manifestation of there's something in the brain that triggers a symptom, it's even more counterintuitive. So it comes to no surprise as to when people first learn about ECT that it's counterintuitive. It's only when you learn about the details of how it works and how different is epilepsy from triggering a seizure with ECT, that's only then when it starts to really make sense. So I didn't want to um, not acknowledge that aspect of the counterintuitiveness of this treatment and the stigma that it has associated. And perhaps in the discussion that I need to get to very soon, this will emerge. I talk about the efficacy. We use it a lot in severe depression, and we use it a lot in older adults, geriatric psychiatry, because it's a very effective treatment, and it seems to be particularly effective in older adults. Just one slide to say that at this point in time, we know a great deal about what does a controlled seizure do in the brain. And there's a lot of things that happen, and some of them include the increase in cells, both astrocytes and even new neurons kind of grow in the context of ECT. And there's a lot of other things that happened in this context. But I want to kind of bring your attention to the fact that one of those things that happen when you deliver ECT and you trigger a seizure is a massive release of dopamine. And so that is what made people, to begin with, think, oh, maybe if we use ECT in the context of Parkinson's, maybe that's what's going to treat depression. And what's going to happen to the motor symptoms? So there's no randomized clinical trial of ECT in Parkinson's, but there's a lot of literature looking in small case series and case reports. And they all report the same, that ECT is as safe as it is in depression, and that it does help with severe depression in the context of Parkinson's, but also in the context of psychosis, which in Parkinson's can be a situation hard to treat because the medications that are used to treat Parkinson's increase dopamine, and too much dopamine can lead to psychotic symptoms. But so you need the medications to treat the motor symptoms, but when they are causing psychosis, that's problematic, right? What these case series and case reports show as well is something that has intrigued psychiatrists a great deal, and that only recently we've been able to convey to our colleagues in neurology, which is the fact that we've observed that some motor symptoms kind of improve in the context of giving ECT. So again, this may or may not be related to that aspect of release of dopamine, but it is an intriguing possibility. And I believe this is going to be, if not my last slide, maybe the last second. Magnetic seizure therapy is that new treatment modality. And I mentioned before that it also requires general anesthesia. We don't want the person to be awake when we trigger the seizure. But it seems in primary depression that it might be associated with fewer cognitive side effects. So that's what led me to apply for a grant with a neurologist at the Pacific Parkinson's Research, Dr. Silke Creswell, to do a trial doing magnetic seizure therapy for people who have depression in the context of Parkinson's. And now we are in the later stages of setting this trial app in the context of COVID-19, it's made it a lot more complicated. So it might take us a few months from now, but we are hoping that come the fall, we might be able to have this trial up and running, and we'll be for sure sharing more information on the lab website as well as the Pacific Parkinson's Research Clinic when the trial is activated. Last slide, summary. We've learned that depression is very frequent in the context of Parkinson's disease, and that is beyond the adjustment, the understandable adjustment that happens to the diagnosis, that it impacts quality of life, and the treatments include lifestyle interventions. So I didn't have time to cover the aspect of being very respectful with sleep patterns, with diet, exercise. It should be thought as a medication. So I don't want to kind of go through the presentation without acknowledging that that is part of treatment, and that antidepressant medications can be tried. They can help, but when they don't help, we might need to look for other alternatives. And questions and comments from the audience. Thanks so much for listening.
Thank you, Dr. Vila. I did have a question. So if someone suspects that they are having depression, what should their first step be?
Excellent question. The first step, and probably the most simple one, is to talk to their family physician as the first step. Family physicians are well equipped to get a first impression of whether this is a situation that it's happening, and many times if it's a mild to moderate presentation, they might even feel comfortable trying a treatment, a first antidepressant. In my experience here at the clinic, neurologists often feel comfortable as well of just trying that first medication, and when that doesn't work, then they referred to psychiatry.
Okay, we do have a question here. How effective is exercise for depression and Parkinson's?
So I'll start by saying what we know, and we know that exercise for major depressive disorder is an effective intervention, particularly for mild to moderate uh, depression. I am not aware of the same studies in the context of depression in Parkinson's, but I have no reason to think that is not effective as well. And again, anecdotally, my observation is been that the people that I've seen at the clinic who are able to stay active usually are able to fare better in terms of depression. So the bottom line as a clinician for me is I always make emphasis for people to be as active as possible as they can be.
Okay, and we have another question here. You mentioned that antidepressant medications have moderate efficacy in depression and Parkinson's. Does this mean that this efficacy is lower than other types of depression? And if so, do we believe that low dopamine is responsible and part of the treatment is levodopa-carbidopa?
Those are research questions. I don't have the answer right now, but I was hinting at perhaps that's what's happening here. Perhaps depression in the context of Parkinson is a bit of a different illness as major depressive disorder, and that's why the treatments that we use for major depressive disorder don't work as well for Parkinson's. It's an area of research. Um, on the other hand, you can make also the argument that if people are already taking medications for Parkinson's that have an impact on dopamine, that should treat the depression if it's a purely dopamine related condition. So something else going on there. Um, and now I'm going to share just a very personal intuition. We don't know this, but when I was saying earlier in the presentation that some of the symptoms associated with Parkinson's, the non-motor symptoms, involve the autonomic nervous system, maybe that's where the clue is. So we know that the autonomic nervous system is affected. There's all these issues with uh, blood pressure, uh, with bowel movements, constipation. We know the autonomic nervous system is very important in depression. So maybe there is the connection. Completely personal opinion and a hypothesis.
Okay, and another question we have, so of course medications all have their side effects. Are there drowsiness as a side effect, or is a less common side effect?
Excellent question. There are different types of antidepressants, and some antidepressants are associated with drowsiness, and they kind of help with sleep. And sometimes that's a strategy that we use if the person is also struggling with sleep difficulties. So we use that antidepressant that can help both with sleep and depression. And but sometimes the person is not struggling with sleep issues, and the antidepressant has that carryover effect in the morning, and the person still feels sleepy. And so in that situation, then if that becomes an issue, we might try antidepressants that do not cause that drowsiness.
Okay, thank you.
No
So if
problem.
anyone else has any other questions or comments, please feel free to type them in the chat box. We do still have some time here today. While any other questions may be coming in, I did want to mention that at Parkinson's Society BC, we do have a free short-term counseling program available.
Hmm.
So if you are experiencing depression, that support is available to you. At this time, all of our sessions are provided over the phone. And if you would like more information, please feel free to give me a phone call. We can be reached at 1-800-668-3330. You can leave us a voicemail and we'll give you a call back as soon as we can. Or you can send us an email and I can give you more information about that as well. But we do have a few questions that came in the chat box here. Okay. So are persons with pre-Parkinson's history of depression and whose depression was in remission at the time of the Parkinson's diagnosis, are they at a greater risk of a new episode of depression following the diagnosis of Parkinson's?
I would say that's the case. So it doesn't mean that there's 100% chance that that's going to happen, but certainly there's more risk. So I think that's an area where there's enough data and the research shows that that is the case. There's more risk, definitely, because of both aspects. So on the one hand, there's that aspect of the adjustment and the impact of the diagnosis, but there's also the kind of the biological aspect of Parkinson's kind of maybe triggering symptoms by themselves. So yeah.
Okay, and another question here. Are you aware of the relationship between faith and depression? Do you know of any research indicating people with strong faith um, can use that to combat depression?
So that's a very interesting question from many angles, and there is some research looking at whether societal changes and the decrease in uh, in practicing religion and the changes in the structure in society have an impact. Um, Most of the time, the majority of times, uh, people who have a strong faith also have a close network of support as well associated to their faith, and that network it's certainly very helpful. Also, a set of core beliefs that form and that help with purpose, uh, that are core and guide can be supportive. So it can be a source, certainly a source of support. People who don't have strong faith oftentimes have other ways of finding that purpose, that network of support. So I think that would be my take. There's another question about gabapentin and if it's good for pain and whether it can be stopped at any time. So gabapentin is a medication that has been used and is used a lot in the context of chronic pain, and it can help with chronic pain. It's important not only with gabapentin but with any medication if it's going to be stopped to do that progressively. So what that means is instead of one day to the other stop taking it, slowly go down on the dose, because what we are learning is that with any medication that we take that has an effect on the brain, if we take it over time, what the brain is going to do is it's going to adjust. So if you remove it completely and abruptly, it's gonna it's gonna miss that medication. So that happens with medications for Parkinson's, antidepressants, with benzodiazepines, with any medication, and gabapentin is no different. So uh, it's important not to stop it abruptly.
Okay, well, I think that is all of our questions for today. Thank you again, Dr. Vila, for taking the time to speak with us this morning and for putting together this presentation. It's very, very much appreciated by the community. And as I mentioned earlier, if anyone has any questions, please feel free to send us an email or give us a phone call. And I will be following up shortly with the recording of this presentation as well as the slides. Thank you very much, everyone. Have a wonderful day.
Not a problem. Thanks so much for the opportunity to present, and I've enjoyed a great deal. Thank you.